In progress.
All right. It looks like it's just now
It's
2
just now
o'clock.
2 o'clock.
Oh, I'm sorry, I'm echoing. So we are clearing out the waiting room. We still have several trying to log in. I believe I saw 3 committee members log in.
That's going to be correct for today.
Okay. Okay, perfect.
Do you want to do roll call in a minute?
We sure can. Give me just a second. We're about clearing the waiting room. Okay, it looks like, and I do apologize, I'm getting some feedback. It looks like I've got Dr. Bobrowski on. I have Dr. Gray and Dr. Petrie. Is there anyone that I missed? Okay, you do have a quorum.
Okay. Well, thank you. And we want to go ahead and get started and want to welcome everyone to the dental TAC meeting. And we do have a quorum for our meeting today. And Dr. Carol Braun will not be able to be here today due to a family issue that has come up. And I'm sad to report that Dr. Phil Schuler is having to resign from the TAC, and he apologizes, but he's got some health issues. And he said he has always enjoyed being on the TAC, and if he gets his health straightened back up, he'd like to return. But you all, let's all keep him in our thoughts and prayers. He's going to need a lung transplant, so he's got some serious health issues going on. And we will go ahead and approve the minutes from our last meeting. If one of our TAC members would make a motion in a second, that'd be great.
Motion made, John Gray.
Second, Joe Petrie.
Guys, do you mind to
All right.
turn your camera on for me for the open records law? Sorry.
Well, you have to tell me how to do that.
You should have a little video like icon next to your microphone.
John, mine comes up on the lower left corner.
Is that working now?
Yes, sir. Thank you.
And so that's a unanimous vote. And I'll move on to old business. There's a few things that DMS was going to look up for us from our last meeting. And I'll just got some of them listed. Like I say, some of these things come up right after I send in it never fails. Every time I send in the agenda, I'll get some pretty important stuff that we need to talk about that comes up the week or two before our meeting. But I was just interested to find out why a change was made. It used to not be any criteria on restorative limitations of a time frame to repair something. And then it went to 6 months, and then it went to 12 months. Is there a reason this was made?
Yes, sir. This is Justin Derringer with the Department for Medicaid Services. Can you see me? Oh, yep. All right.
Yeah.
Okay. So the change from 6 months to 12 months, that was originally on the fee schedule for 12 months. I think it's been in the system as 12 months. We never had it at 6 months. So I think we had a fee schedule that had came out. We had as you all know, multiple fee schedules this year in 2023. And so in adding all the codes that we've added, changing all the different codes and limitations, the majority of that came from provider feedback. A lot of it came from this tax feedback that we were able to make a lot of changes. And so several typos were on some of the original or some of the fee schedules that kind of popped up on there. So in the system, it was always 12 months. I think we mistakenly had it listed at 6 months at one point, but changed that back to 12 months. And that's just based on all of our research from surrounding states. But since it came up, and since you had asked the question, we started looking at that for 2024's fee schedule. And that's something that we're still kind of pending, but may be changed when 2024's fee schedule comes out.
Okay. See, when Justin, when you deal with us old gray heads, we go back a long way on some of those old fee schedules, and it just, I don't ever remember it being on there in the past, but I would say as a recommendation that I'll see what the other TAC members think too, but as a recommendation that might need to be looked at. A lot of our patients are, especially our adults, are, they've just got fillings on top of fillings. And a lot of times it can be a front tooth, it can be a back tooth. And some of these folks are bruxers, grinders, clinchers. They'll break off a front tooth and boy, they got a wedding to go to, but you just fixed it like 7 months ago. Now, does that become a non-covered service and they would just have to pay out of pocket for it? So see, that it puts us in the dilemma of, sometimes folks can't pay for it, but what are we to do? So I don't know if there are any comments from other TAC members. I've got several patients. I've got 2 groups of them myself that are traumatic brain injury patients. Some have teeth, some don't, but a lot of the ones that still do are pretty heavy bruxers. And unless we just want to go ahead and put caps on all of them, that might be the next best thing to do. But see, up until this year, caps weren't allowed to do. So I think we would need to maybe look at that for 2024. And moving on to on our fee list, it on the community health workers, it uses the CPT codes, but dentists can't use those. We can use the CD codes. And I know we've been talking about that off and on. Justin, do you all have a way to work around that, and seemed like we had something just about worked out, and I forgot what we had on it.
Yes, sir. That's okay. One thing to remember too, in the previous topic, previous fee schedules didn't have any of the limitations, didn't have a lot of limitations. We did a fee schedule project this year in 2023 because the fee schedules didn't always match what billing actually paid. The fee schedules didn't have a lot of the limitations, some of the different things that you all would like to see on the fee schedule when you're actually working on it. And so during this fee schedule project, we went through, we made sure that all the fees were accurate as far as what they were actually being paid in the system. We made sure that everything matched up. And we tried to include any limitations that were listed in the system itself. So you'll see a lot of things pop up that were not previously there. Maybe they were already in the system, but they maybe not were on the fee schedule. As far as the CHW issue goes, we had several options that we had put forward. We sent those options in August, I think the end of August, to some of the MCO dental providers. to get comment on. We've reached out a couple times in the month of September, and I still haven't heard back from those. So one of the things that I'd like you all to do as a TAC, we've got there are some issues. As you all know, those D codes came out this year, and they are completely different than the CPT codes that we use. And one of the biggest issues, or the two big issues, one is when CMS audits, we have to make sure that the CPT code match, or the D code matches what we're doing. And the other big issue is that on your all's billing system, they don't use modifiers. And so those modifiers would have helped us a lot too, to come up with some solutions on the difference between the CPT codes and the D codes. But in the meantime, while we're still working out a solution, one of our options that we suggested was to use one D code for CHW services. And then you all just bill an amount for those as far as how many times that's being billed. It'd be one flat fee. So you wouldn't be able to do a group of people all together, because that would be the issue of us trying to figure out how to code that, and you ought to bill that, the groups of people together. But so far, what we've seen, about 90% of the billing for CHW services in 2023 has been individual billings. And so I think we could go ahead and resolve that for you all while we work out the issue of how to work in the other fees for providing CHW services to multiple people at one time. So that's an option that we would like to put forward. We've put that option forward to some of the MCO providers, making sure that would work in their systems. But I think that's something that we would like to move forward with, as long as it works in the system. I think it should. I think it will. And as we're waiting, we may go ahead and just kind of implement that and see if that works out. And then if it doesn't, we can do something else. But we've been waiting for a few months now, and I think it's time to kind of move forward with that. So you'll see something within the next couple of weeks. We'll send out a provider letter talking about the exact solution, and it won't be exactly what other providers have, because your all system doesn't use modifiers, but it will be at least something to get you 90% of the way there, if that makes sense.
Yep, that makes sense. Yeah, thank you. As you were talking, that kind of came back to me that we were looking at one code, a D code, to come up with to handle that. All right, great. There's and I'm not really on that fee schedule project myself, but I've noticed and sent in some suggestions. But there's still some typos and things that need cleaning up in there. One of them was the cleanings, and just wondered the rationale for it. It was changed to per provider per 6 months, and that was could allow patients to go once a week and get a cleaning done.
That was a typo that we've corrected. Of course, we that won't, it takes a while to actually make the change show up on the online. But if you were to go get one of those codes billed, say at your office, and then that same individual went to another office, that code would be denied. So that's something that's not in the system. It was a typo, and we're in the process of changing that.
Okay, good deal.
Justin, this is Julie McKee. Wasn't it added per member, per provider, and both of them applied?
Explain that again now.
That the Profi code was services per member, comma, per provider. So both of those would be applied to the service, so that the provider couldn't do them every week, but the member couldn't get one every week.
That's correct, although it's kind of incorrectly worded on that fee schedule. I believe just per member would suffice. So we're looking at that and then making that change.
Okay.
Okay. And then another one, and we're getting some phone calls from the pediatric dentist on the code, the D2934, which are those stainless steel crowns. And again, the same thing. It was a typo was in there of per, and I would say it was per member, per provider, but I don't want to guess because this is your all's job. But one of the other things was it listed it as for primary teeth, but in the columns it also lists it as eligible for teeth 1 through 32, which are permanent teeth. And then another problem is out beside that, usually pediatric dentists and general dentists that see children and put those stainless steel crowns on it's generally as a temporary crown to better hold the tooth in position because it helps to create and leave space for the permanent teeth instead of extracting the tooth. Now the problem is it's down there as 1 per 5 years, and that's what the pediatric dentists are complaining about, is that sometimes it's like around Halloween or Easter when all these kids get all these candies. And it happens during the year anytime, but they get these candies and they'll pull a crown off. Well, in pulling it off, they chew again and again, and it just mangles the crown. And so the dentist or the pediatric dentist would have to put another one on. But and I don't know if in doing the fee schedule project, that if someone just saw the word crown and put it down as 1 per 5 years, just like the permanent crowns are. So that might be something to look at when to not put that kind of a limitation on the pediatric dentists and the GPs that are doing a lot of those for the children. I don't know. I didn't know if you all had recognized that or not, or.
We actually did. That's one of the things that we're looking into for 2024. It may be later in 2024 because it requires a fiscal analysis, because that's actually the way it's in the system. So, but we are looking at it and seeing, what kind of fiscal impact that might have.
Okay. Let me see here. I'm trying to make myself some notes on some of this so I don't have to ask again on these. Well, and it was kind of the same thing, Justin, with those codes at D2930, 2932. Those are kind of the primary teeth codes. And then there's another one, D2951. It actually uses a different tooth numbering system than I think the rest of your fee schedules. There's a Palmer numbering system, an FDI system, a universal numbering system, and as best as I could see, that one right there picked out a different tooth numbering system than anywhere else in the fee schedule. So that's another one y'all might want to look at.
I'm taking some notes too, so we'll look at
Okay.
that. I did want to let you know, I saw number 4 where we've had multiple requests for increase of fees, various fees. We have different D codes that are listed on there. I think at this time we have 3 different decision memos that have been created and shared, and those memos go up, show different options for increasing rates. We've already done research in other states. When we do research, we contact each state directly and get their current rates that their system's actually paying. We don't use any kind of anything that's put out by anybody else. So we contact those directly, and we compare and contrast those, and then we send those in and do a fiscal analysis of where we at, or what would, additional funds we would need, and if that funding is available. So those answers to all those should be sometime in 2024 with those with the budget and where we are with those. We did have one code, and that'll be kind of coming out a little bit later as well. That kind of falls in that group, and that was actually incorrect on the fee schedule. It was billed at a higher rate than, or it was showing a lower rate than what it was actually being or supposed to have been paid for. So that code, and I thought I'd had that written down. I can't remember exactly the code. Kelly Kitchen's on here. Kelly, do you remember what code that was exactly?
Yes, it's the D1110. It's currently showing at 40, should be 6013, and it is showing, let me look.
4625.
Yes,
Yeah,
it is
yeah.
at 4625. It should be $60.13. So we'll be updating that.
Yeah, D1110.
Yeah.
But the rest of them, like I said, are in the decision memo process, and we'll have answers to those as we get the fiscal analysis back. Probably be first part of 2024.
Okay. One of the things I just got a report, it's talking about looking at these other states. And I just got a report from Indiana, and they were talking about the number one reason dentists don't. They did a study up there that don't accept or stopped seeing Medicaid patients. Was the number one reason was because of the low reimbursement rates. And I know at our Medicaid forum, one of the things that we had done was tried to talk about moving Kentucky from 49th in oral health care, move us up that ladder. And I know Dr. McKee, they did a study, and even through the KDA, it wasn't a scientific study done through the KDA, but in talking to most of our members, that the low rates that have not been increased since 2002 was the number one reason why some dentists would totally drop out of Medicaid. Some dentists will keep their Medicaid number but stop seeing patients. And I noticed that other states around us are even involved with their legislature on improving the dental rates for people in their other states. I know Maryland is another state that just this year started doing adults, and Maryland's on a lot of their rates are much higher than what Kentucky is getting. But my goal is just to see that patients get good dental treatment, get good oral health care. But if there's a lot of things out there that are hindering the business process of it, well, we got to see what we can do, or else I've told some other folks, if you can't pay for it all, well, you may have to drop some items and pay a little better on what you can do. And for instance, I got let me turn my page here. I got a report from a dental group, and I've got it kind of in a chart form, but started in 2019. Their costs per day to run their offices went up 3.5% in 2020. went up another 11.7% in 21. And for 2022, they went up another 22.4%. Our costs to run our business and provide the care is astronomically going up. Wages, for example, a patient coordinator is getting $43.58 per hour in 21. Now it's gone up to 49, 17, a 13% increase. Dental assistants have gone up 12% in 1 year. Hygienists have gone up 24%. I've got the more numbers with it here, but part of the problems is inflation, and our workforce shortage over the last few years has really taken a hurt on any kind of profit margin we used to have. These are just some reports that I've gotten from other dental groups. So I just wanted to share those. Let's see. Any TAC member got any other comments or questions on the fee schedule? If you don't, we'll keep moving along. All right, hearing none. I just wanted to give a brief report on our Medicaid forum that we had at the KDA annual meeting. And we really had a good turnout for the Medicaid forum. And again, I wanted to thank Avises for providing the lunch. I wanted to thank all the participants that came. And I wanted to especially thank Commissioner Lee for being brave enough to show up. But I think she was the highlight of the show because she was there to answer questions. And I thought she did an excellent job answering those questions and, fielding the concerns that practitioners had. And I just wanted to give a brief report that I thought it turned out to be a very good forum. Now, is there any other old business that we need to talk about? Okay, I'm gonna move on to new business.
Garth, John
Yes.
Gray,
Yes.
one second. I would like to second your comments about Commissioner Lee. I think it was extremely helpful and extremely well received. I think if there's any way to make that a yearly kind of thing and get in touch with the dental providers, I would encourage that because it certainly was very helpful this year.
Mm-hmm.
Hi, Dr. Gray, Dr. Bobrowski. I've been sitting back listening. Thank you all for your kind words. I think, definitely as long as I'm here, I'm always up to come to the conferences. I think that it's very important to listen to our providers that are treating our Medicaid members. And I think, regardless of who's in this chair, continue to invite someone from the department to those meetings. I think it was a really good conversation, and I appreciated learning some of the issues that the Medicaid providers are wrestling with right now, and just really look forward to future conversations to make sure that we're doing all we can to not only improve the health status of our members, but to take as many administrative burdens away as we can from our providers so they have more time to treat our members.
Well, we really appreciate your willingness to talk with us and try to work out some things that, like you said, to take some of that administrative burden away. And I'd really like to see all of us, even the other TACs, work together to move the healthcare in Kentucky up those ladders, because Kentucky's not, as country folks, ain't doing so good. we just need to, we need to help people. And I've got a little thing else down there in new business to talk about that just briefly to look at some things and ideas. And, but I want to, again, thank you, Commissioner Lee, for all your help and support and giving out information, and just be willing to talk with us. That means a lot. I'll go on to new business. And of course, I've already sent this to Commissioner Lee, but there was and I'm sure hopefully it was just a typo on the oral pathology codes that had been listed as for all ages. But then I guess in one of the new revisions, it got shown as only for patients under 21. So I put down, is this a typo or has this been a major change?
Commissioner, would you like me to speak about that?
Yeah, I
Okay.
think you can go ahead, Justin, and I'll
Okay.
chime in if I need to, but thanks.
Sure. So, like I said, when we, as you all know, we updated this fee schedule multiple times in 2023. This was a typo that was listed on the fee schedule, briefly. That wasn't long on the fee schedule. I think it may have been on there for a couple weeks, 2 or 3 weeks that was on there. We corrected that. It's never paid in the system that way. However, because of that, it's been brought up that may be something that is needed, and I think we're currently looking at that, and maybe Commissioner Lee can talk a little bit more about that.
Yes, so we have had some conversations about the oral pathology codes. There's just, there's a small subset on the fee schedule, and it really kind of doesn't make sense for us to cover them under 21 and not over 21, because I would assume that most of the biopsies that you all do are for over 21.
Right.
So we are going to pull together a policy. We're just looking at a few other things, but we'll pull together a policy. We are going to start covering those for over 21, but we're just getting a little bit of information together. We're going to do that policy, send it out to the MCOs, and of course, circle back with the dental community, keep them in the loop on what we're doing and what that policy is going to look like. So we'll have something out, hopefully before the holidays on that code and there, what our policy is. But we will be covering those.
Okay. Thank you very much. The oral surgeons and the universities were starting to get nervous on that, because the oral pathologist and I got some letters from some of the oral surgeons that they commented about how valuable an oral pathologist is compared to just a general pathologist. That it's like you said, it's almost a subset of the pathology departments that are highly specialized in our area. So thank you again for working on that. And the next item was and I know we've talked about this before, but since we've got some more expansion codes in orthodontics, or if a dentist starts a root canal or starts a denture, starts a crown, those dentists have incurred some material bills, lab bills. But what happens if the patient becomes ineligible right in the middle of treatment?
That's a good question. That's something that we have met multiple times. I've met multiple times with CMS trying to get that figured out and evaluated. That with all provider types, if a member is showing eligible on the date of service for you all, and then you get something later saying that member is ineligible, at that time, we always make sure that is paid and covered, because that was something that was out of your all's control and out of our hands. And it's really about that, then becomes about that date of service. If an individual, so there's multiple scenarios, but for an individual to lose coverage Now, if it's a matter of just switching MCOs or MCO to fee for service, we have discussed that with the MCOs, discussed that with our billing providers to make sure those errors don't occur. And if they do, we're encouraging all providers just to reach out. We'll make that, we'll get that corrected so that they are paid for that regardless of timeframes or any other issues. But in the case of them specifically losing coverage, there are several reasons why individual loses coverage. If they lose coverage because they simply didn't turn something in, or with PHE ending and everybody having to do redeterminations now, as long as they get that information in, they will backdate that coverage to when to make sure that there's not a lapse in coverage due to that. So that's not really an issue for providers, although it may be an inconvenience at the time, but they will backdate that and we'll make sure all those claims get paid. If the individual loses coverage because they have other insurance or because they are no longer in the acceptable income limits, unfortunately right now there's nothing we can do about that. CMS won't allow us to pay those. We're looking at some other states that are trying to come up with some ways to maybe do some things, and we're in continuous conversations. We have one actually scheduled, I think, in the middle of January with CMS and a couple of other states that have the same question, trying to come up with some unique solutions. But as of right now, there's nothing we can do about that scenario. So that's kind of where we're at with that.
Making a note there. One of the things with you when you're talking with CMS, because I know like on a root canal or a denture, a crown, we'll put it in our system that we've kind of got it started, but as the dental rules are, we can't bill for it until the procedure is complete. But something to think about would be as if when talking with amongst yourselves and CMS that if the dentist can show in their records that the procedure was started while they did have coverage, that maybe you would, even though they have, maybe now have other insurance or, they're, even if their income won't cover it now, well, maybe it would cover, at least the paying the bill for the dentist. We're starting to get a few phone calls about that setup, and I know, I guess maybe where people are coming off of the emergency enrollment plans, they maybe are halfway done a procedure and then now they are no longer on Medicaid. So we're starting to get a few phone calls about that.
And Garth, I think it also becomes to be a patient care situation that becomes a challenge. I certainly feel it for people in the midst of a root canal, because an incomplete root canal obviously in many ways will doom that tooth, and that start of that procedure will lead to failure of that tooth. I can speak from an orthodontic perspective that if a patient loses eligibility, where we have the 3-tier payment system in orthodontics, if they lose eligibility before the second or third, but mainly specifically before the second, we have a patient that has lost eligibility. We did receive an upfront payment, but we don't have a payment sufficient to cover our costs in the case, and that leaves the patient in a difficult position of what they are to do, because many of these people, even though they are above the margin to stay on Medicaid services, they don't have the ability to cover their health care to the degree of many of the things, such as orthodontics, such as finishing a root canal. And then it puts the provider in a very difficult position, because what we do in our practice, and what I think most of the people that are involved, certainly the TAC members that I know, you finish the case, you finish what needs to be done for the patient, but you do so at a loss. That's a challenge when we're already at treating on the margins. but you can't abandon the patient. I mean, obviously, our Hippocratic oath would not allow us to do that, and nor would we want to do that. But to start a case and then not be able to finish it financially, whether it's a root canal or orthodontics, any of those aspects, I understand why CMS is not wanting to cover. We discussed this with patients that turn 21 and that were a child service and they age out. And we have to be mindful of how we treat that. I'm not sure there's clarity from CMS or from the MCOs how we should treat that when patients come to us asking for care, and we know that they're going to age out of their eligibility, and we know they won't be able to continue to have their full fee covered, what is required of us in those cases. But even beyond that, it's a good number of patients that lose eligibility that we have no way of knowing. It's not an age issue, and we're in essence left holding the bag. But it's more than left holding the bag, because we have a patient that we have a responsibility to, and we're left without any means to financially help that patient finish out of our own pocket, which is what we do.
And thank you all for bringing this up. I'll reach out to other states to see how they deal with this. I'm hoping that our new, we have continuous eligibility for children now for 12 months. So typically if a child was enrolled in the Medicaid program and their income changed, or they had some other change in circumstance in their house that made them ineligible for Medicaid, we would terminate them. But now, regardless of that change, we will have 12 months of continuous eligibility for children. Maybe that will help a small subset of children. I'm not sure how, as far as the orthodontic piece goes, but as far as root canals and that sort of thing, let us reach out, see what other states are doing about this, and see what we can come up with as a game plan.
Now, Commissioner Lita, you always tell us to think outside the box.
I am thinking outside the box.
Okay, all right. I was just making sure.
And I think if we could somehow quantify, what we're talking about, see how big of an issue it is, and see what we could do. I don't know how we could get that. It might be easier in orthodontics to go back and see how many kids age out or how many kids lose benefits in the past, have lost benefits before their treatment was completed. But for the root canals and stuff, I'm not sure how we can quantify how big of an issue that is, so that we can look to see, what can we do and what can we take maybe to CMS, or what could we look at as a way to make sure that those individuals complete their treatment. Because as Dr. Petrie said, you can't just abandon the patient. So we've got to figure out something that we can do.
Well, see, and that's where, like in my situation of a general dentist, we're doing more dentures for folks, and making dentures are typically your better dentures are, they're a multi-step process to make these. And I mean, you can easily run up a $800 or $900 lab bill, and then you're stuck with their the patient can't get in to to finish it up for various reasons, and that's a big chunk of money to not get any reimbursement back on it. But anyway, let's continue to work on that one. And I made a note about that. Okay. The next one, I want to commend the ADA that they did have a fee report out the last few years, and we've been telling them and say it's not right, but they finally came out here in the last couple of months or something and admitted that their Medicaid fee reimbursement reporting did have errors in it. It wasn't as much as what they originally said, but and Commissioner Lee sent me a new report that listed Kentucky as is 19th for children and 26th for adults. The only thing is even though we're 26th in reimbursement, it's reimbursed at 34.3% of the percentage of the charge that was turned in. So that's kind of part of that problem that in doing dentures or some of the other products that with the expansion is sometimes our lab bills really jump up there, and that's another thing that those things haven't stayed stationary like back in 2017 or 18. Those lab bills have really gone up, and to tie in with this one, and I'm not going to name any names on dental insurance companies, but some of these have not adjusted their fees and reimbursements the same thing as like Medicaid for years. One company, a big company in the state, hasn't done anything since 2019, which it doesn't sound like it's that far ago, but it is. And like with Kentucky at the adult rate of 34.3%, this is what ties in to one of our dental schools reported that they'd billed Medicaid for, I think, is fiscal year 22 there, over $12 million in care, but they only received right at $4 million. So they're just saying that they've got a budget, but they're worried about being able to sustain what they do. And you all know that our dental schools are sometimes our last resort to send folks to. But another study that I've seen is that typically dental overhead in the office would run anywhere between 65-70%. The last report I saw is now at 85 to 92%. So it's just not leaving us a lot of wiggle room to get ahead when that $20,000 suction machine goes down, or your computers have got to be updated. There's no cushion. But on under new business item number 3, and I need to maybe explain that a little bit more, because I got this information from 2 different sources, was that Kentucky is 50th nationally in insurance reimbursements. So even though somebody has insurance, here again, Kentucky is ranked 50th in reimbursements from the insurance company. So if you're dealing, and I know for a fact that some of our specialists in our area have even stopped accepting some insurance plans. So it's a lot of times it just gets down to a business decision of, well, I can't keep doing this procedure at a loss. And if somebody wants it done, well, they can just pay the fee and go on. It's kind of the business attitude, but they can't keep doing it at a loss. I'm going to move on to number 4. And this is just a thought that, like Commissioner wants us to think outside the box on things, but was to develop maybe a section in Kentucky on KMAP that helps the members in personal responsibility in the care of their own bodies, in preventive measures, in nutrition, in basic knowledge of their body, keeping their appointments, and they would also be in a commitment to change to a healthier lifestyle, and give rewards to members for this commitment. Like if they lower their blood pressure, they get a better A1C or blood glucose reading, physical therapy improvements, a decrease in the cavity rate, or at least finish a basic dental treatment plan and start having better oral health outcomes and then get rewards. Not like it is now where I had a lady here 2 weeks ago. She told me that she got a $100 gift card from one of the MCOs just for filling out a survey. In other words, reward good behavior. Another person brought up to me, said, well, people are getting $50 gift cards to get their exams done, but the dentist gets between $26.50 and $32.50 for doing the exam. Plus, out of that, you got to pay staff and supplies. So I'm just putting that out there as an item of thinking outside the box. Is maybe we should tie some of these rewards and awards to the Medicaid members to, well, let them have a little more skin in the game. That, well, we've got to see some improvements in what you're doing. It's just an idea. Any comments from any TAC members or? All right. Under new business, under other, I guess all I can say is just to kind of, we all need to work with our legislators. And if we want to have these good programs, and I have seen so many times when people are just so glad that they have had Medicaid to kind of get them out of a tough situation. So I don't want to make this totally sound like I'm always doom and gloom on this, but and because we want to help our patients in Kentucky have a much better life, and sometimes we've got to work through issues to get them there. I do have a question on, and I think this was reported last year, but I've got, let me pull that up. Give me 1 second here. Let me close out this page. There we go. One of the questions that I've got is, what is the, I've got a few here that, what is the value per MCO on the value added benefits per year? And these are some things that if the other TAC members agree, that we could maybe get some of this in a report, obviously not today, but by our next meeting. So what's the value per MCO of the value added benefits, per year, and maybe by January or our next February meeting, maybe we could have a report on what was done for 2022 and 2023. And
Bobrowski,
And I'm sorry, Stuart, go ahead.
Stuart, on with WellCare, are you asking for like the total spend by MCO on value added benefits? I'm just
yes,
trying to make sure I
what was
understand.
spent on the value added benefits?
Okay, thank you.
Because I know you got a range of things that some of those monies are not. I know you've probably got a budget on those things, but not everybody uses the full budget.
So you would like to know like how much actually was spent, like
Yes.
there's a budget, but how much for the year?
Yes.
For like calendar year 22?
Yes.
And to Thank you, Stuart. You asked my same question, and this is Erin with the Department of Medicaid. And I just want to make sure, so when I send this out to the MCOs, do you just want a lump dollar amount sum, or do you want that broken out per, what benefits were used? Would you, for example, the gift card reward, like on the, do you want that in its own category? How many dollars of that versus, say, and Stuart, help me, your value added better than I do, but do you want those broken out in different categories, or do you just want a lump sum dollar for all the value adds for those years?
And I was going to say, we have a lot. It might be kind of a little bit of a challenge to break it down by each individual one, but
My initial thought was to just a one total dollar amount. And I know you all probably do evaluate those things to see if, maybe one value added benefit is just not used at all, that, well, maybe you can switch those funds to something that is being used. But my initial thought was just a total dollar amount. I know that'd be awful hard to go through each item that you all provide, but let's start with a total dollar amount. That'd probably be a little easier to come up with.
yeah, appreciate that. And we did kind of, to your earlier point, you talked about, I know all the MCOs have rewards programs where we're trying to incentivize, good behaviors, what you're talking about, healthy behavior. They are tied to, preventive visits, getting visits like that. Actually tying it to a member improving in a given area. I don't think we do that. That can become a challenge, but anyway, it's good to think about for certain. But I know we all have rewards programs to try to incentivize members, including like quit smoking, but a lot of different things, controlling, diabetes and blood pressure and various things. But anyway, back to the dollar amount would be total dollar.
Okay.
Thank you.
I just saw another saying from Albert Einstein this morning. It's like, if you keep doing the same old, well, I forgot this full saying, but you're not gaining anything. Well,
and expect a different result.
The same result. Yeah.
Right. Exactly.
But anyway, that's what I was looking at is, are there things that we can look at and maybe even have a section of Medicaid that these patients would agree to, well, getting either an additional reward if they complete a dental treatment plan, get all their cavities done, get their cleanings done, just the basic stuff, or if their blood pressure improves, those are things that benefit or have better health outcomes. And I did get a report from Medicaid. It was the number of Medicaid dentists per county, but I am so sorry that I can't find it. Like you all, when you get about 70 to 100 emails a day, sometimes they get lost. And I'm not saying that my little chubby fingers might accidentally hit the delete button on some of those that I'm getting rid of.
Dr. Bobrowski, we have a couple hands raised.
Yes.
Danita, I believe you were first, and then Dr. Terrio. You're on mute, sweetie.
Hi, Dr. Bobrowski. This is Danita. I'm with Quality and Population Health. I'm Equity and Determinants of Health. We thank you for uplifting your concerns about the value added benefits. And we just want the TAC to be aware that our team is also interested in connecting the value added benefits with the health outcomes and figuring out how we can best get our enrollees to utilize those and to connect those with health outcomes and tie those to the population health reports. So that is something that is on our radar. We are working on that. So I just wanted to acknowledge that to the TAC.
Great. Thank you so much.
And hi, Dr. Bobrowski. I actually have been thinking about this a lot because when you get the information from the MCOs, you're going to be surprised about how few members take advantage of those value added incentives. And I've always wondered that, like, if you can get $100 for going to a visit, why, that's a free $100. Why don't you just go do it? And I think it actually goes back to that Maslow's hierarchy of needs that we all learned sometime in college, that, that baseline level is you need to have shelter and food and safety before you can look higher up. And you don't get to that personal responsibility until the very tip top of that pyramid. And so if you're a family or a member that is struggling with food or housing instability, you're just not going to be on. It's not going to be anywhere on your radar to control your blood pressure or go to the dentist or anything like that. And so I think that's where the social determinants comes in, and population health is to actually, you got to help try to address some of these problems that are at the bottom of the pyramid before you can even think to make any movement on the top. So I do agree it's personal responsibility, but in the same time, people just can't get to that level without, climbing up from those other levels. And so that's where the problem is, I think.
Well, I agree. It's just, and that was kind of why when I made that comment was maybe develop a section of KMAP members. It's hard to make a blanket of policies that you'll get 100% good responses from. We just know with dealing with humans or puppy dogs, that won't work, but I just hear, well, and it's not even with just Medicaid patients, it's with everybody. You've got all kinds of people that just have even got regular insurance that the doctors, the physicians have trouble with compliance on, like diabetics of them they're just not eating what they are supposed to do to help their diabetes. And it just creates other health problems. But I don't know. I'm just trying to think outside the box on trying to get something going. And I hope that we can all put our heads together and just help with health outcomes. But thank you. Let's see. There was a report that we asked for a while back. I don't remember receiving it, but it was on a report from the MCOs on paid claims, and it was what was paid at different levels per quarter. We never did get that report that I can recall. We used to get it a few years ago, but we've stopped getting that. But maybe if somebody from DMS can help me, because we've already sent that in to you all. I think we sent it back in maybe in April or May.
Dr. Bobrowski, this is Erin. I'll search my records for the data requests, and I
Okay.
apologize. I do see, I was scrolling really quick. I sent a supplemental report in August. Is that the same report or is this something different?
I'd have to look and see what that supplemental is. Because I was looking all week, and again last night I was pulling up your name to see if I could find it under your name or Kelly's or Commissioner Lee's, and I just couldn't find that one that we had requested, because we had requested that. Well, we actually had it a few years ago. It was kind of like paid claims of how many dentists we're getting paid like $1,000 a month from Medicaid or from the MCO, how much we're getting 1,001 up to $5,000 or something like that, and then 5,001 up to 10,000. So we kind of had it broken out.
Okay, I'll go back through my records. I do see a couple of things that I've sent, but I will get, when we get off here, I could go through and actually pay attention and try to pull anything. And if we have
Okay.
not sent you anything, I will follow up, and I do apologize for the delay in that request.
Well, we'll forgive you, but it might be me too. I might have just not found it in my stuff, but I've searched numerous times for that and I couldn't find it. But then I've got another request. What number of procedures require a prior authorization through the fee-for-service group or the MCOs, and the number of denials, number of approvals, but what are you all seeing as the reason for the denial? I mean, is it that we have got to educate our dentists better for their front office staff not sending in the x-rays with the request, or did it not meet the criteria? What are some of those reasons for denials? And then I had another request of, well, what is the number of general practitioners that are Medicaid providers per region? Now, and that may be able to be tied in with that report on the, well, I don't know. I'm not a statistician, and so if somebody is, you can help me on that, but tying that back in with the paid claims report.
Dr. Bobrowski.
Yes.
Sorry, this is Rachel Rarig, Research and Analytics with DMS. And just to clarify, the supplemental report that was sent in August, what is listed on there are the top 10 dental provider counts, the bottom 10 dental provider counts, the top 10 paid fee-for-service dental procedures, top 10 paid dental procedures by MCOs, denied reasons. So if you need us to resend that to you, we're more than happy to do that, but it definitely has a lot of the things I think that you're looking for on there.
Okay. Please just resend that to me, and I'll be looking for it here today or the next few days or next week. And I don't expect you to do it on a Friday afternoon, but it wouldn't.
I've already sent it to you, Dr. B.
Oh,
I sent it to the whole TAC.
Okay, you're special.
Thank you, Aaron.
Let's see. Let's see. Let me look at my little list of questions here. What is the Medicaid fee-for-service dental budget and the MCO dental budget, and how much of that is actually spent on true patient care? We're not interested in, then that would go back again on those paid claims. But we're not interested in. Go ahead. And then the
I
other
think
thing
someone actually unmuted.
Okay. And then what I was looking at, well, what was actually spent, does that come under budget or over budget? If it comes in under budget, what's done with that additional leftover money? Or if it's over budget, where are you getting the money to pay for it? but let's see. And then I've got another question on, and I can send you this list. If somebody you'll give me a who to send it to, an email address, but wondering, well, what is the dental ER usage rate? And maybe look at a yearly comparison, because I know that was one of the things we've talked about for years, was decreasing the emergency room visits, and it'd just be good to track that to see if we are making some inroad. And my thinking is that the more dentists that we can get to be a Medicaid provider, that emergency use of the ER should go down. But if we could look at that kind of as a yearly comparison to see what's been spent at the emergency room.
Dr. Bobrowski?
Yes.
It's Julie McKee. That particular question is something that I'm going to be developing a request with the data people for that, for a completely different reason, but to find out specifically non-traumatic dental presentations in emergency departments. So I will share that when I get it.
Well, thank you. All right. And then I know in the past we've had reports on the failed appointments and the reason for these failed appointments. And it seems like the last several reports we've gotten on that, the majority of the failed appointments had no reason, or there was no reason given. Now, yes, sometimes it could be a transportation problem, or a child may get sick and not be able to come to their appointment, but the majority of those was there was no reason was actually given. But we'd like to kind of follow up with that one and see if there's any change, or just to watch that and look for changes. Is there a way to quantify treatment for special needs groups of patients, or what health outcomes are we actually helping special needs patients? And then another one, and I know when I was looking at the value added benefits, I know there was some things to help ladies in pregnancy, but I was just wondering if there's a way to quantify oral health outcomes for our pregnant moms in our communities, and especially our new moms, that this is their first child. What kind of health information are they getting? What kind of oral health information are they getting for our new parents? And I guess that this kind of ties in too with what is being done for oral health education and treatment recommendations from the MCOs. And I know I did see a few things on the value added benefits, but I didn't know if anybody from the MCO wanted to briefly talk about that. The floor can be open. Just got a couple more questions here.
I believe Justin Derringer has his hand raised.
Okay. I don't get to see those hands being raised, so you got to help me on that part.
I got you. And
All
also,
right,
if you would like to email me a list of all of those questions, I can make sure they get to the appropriate person to get you some answers.
All right. I'll mail them in just a few minutes. Justin.
Yes, sir. I did want to let you know that we have a new system, or I'm sorry, a new report in MMIS, which is the billing system for providers. So when you go into that system, there is a report that is a no-show report and or a missed appointments report, and you can actually run that yourself at any time. It shows you how many missed appointments there were. You can break it down by provider type and reason. And you are correct. The number one reason is still unknown. And that's one of the reasons why we wanted to put that report out there, make it public, make it instant, so that you have access to that 24/7 in order to try to get providers to understand how important it is to reach out to individuals to try to get a reason why they missed that appointment. The majority of those missed appointments may still be something that we can't control, but if we have a large percentage of those appointments that are missed due to transportation, childcare, other issues, we can really focus on getting those taken care of and trying to cut away at that percentage. So I just wanted you to know that that report is out there. It's available to all providers, and it's in that MMIS system.
Okay, I wrote that down. Thank you, Justin. Now, is there a way to get a yearly report on comparing the current Medicaid reimbursements to a regional usual and customary rate of, like, for instance, on the ADA fee schedule? Because I know there's been talk about comparing us to other states. And it really, when I've looked at some of these things, it really is hard to compare apples to apples, because of certain states have limitations. And I think even some of the ADA, I think that the report that Commissioner Lee sent me a while back was they've got Kentucky with the adult level is listed as limited, but this is all changed since the beginning of this year. Some states are extensive, and some states only do emergencies for adults. And of course, it lists as Maryland as one of the states that had no Medicaid coverage for adults, but I believe that's one of the ones that changed for adults January of this year or thereabouts. And the next question I got will be covered by that report that you're going to send me. And then does Medicaid update their records on providers who show that there's been no treatment activity from that provider for years? I know of one dentist that he said, I haven't seen a Medicaid patient for 25 years, but he says, but my name is still on the rolls. And does Medicaid reach out to those providers to see if they can want to keep their name on there? Or I know at our church, it's kind of one of those things you hate to have to do on membership, but we do have a membership committee, and some people have deceased, have moved away, and or they've gone down there at that Baptist church. I'm teasing, but just that's another question I had, and I'll send this to you all. But then one last question: what is the MLR for the dental MCOs only? Now, TAC members, is there any other question that I've tried to cover some bases here and just try to get us looking at our whole package here. So that was the reason for such a lengthy list of questions.
Garth, John Gray.
Yes, sir.
I'd like to go back to number 4. If there's any interest in having dental input into the rewards program, I would be happy to meet with whoever is heading up that rewards area as to some possibilities for dental input. I think you outlined it pretty well. So if anyone is interested, I'm would be glad to make myself available one-on-one or however we need to do that.
Thank you, Dr. Gray. Appreciate that.
Dr. Bobrowski.
Yes.
Hi there. This is Rachel Rarig again with Research and Analytics at DMS, and just wanted to let you and the TAC know that we are currently working on developing a report that will look at different providers, such as dental providers, and see if there has not been a date of service, there haven't been any claims billed within a certain amount of time. So that way we can make sure that the listing of providers, they're actually seeing the Medicaid members and they're servicing them, and that they shouldn't be removed, or they should, based on our findings. So that is something that we're developing currently to look at just that.
Okay, great. Thank you.
Hey, Dr. Bobrowski,
Yes.
Stuart Owen again with WellCare. Just back to when you were talking about ER, I do recall early this year, DMS talking about, I believe last year, $9 million was spent on dental care in the ER. And that's one of their key lobbying points with the expansion of dental benefits for adults. So I would definitely think that would influence the ER, that it would reduce the ER. But I do remember them reporting that earlier this year. I know Dr. McKee's working on a report, but anyway, I do recall hearing that 9 million last year.
That's what it seemed like. I could remember it was a pretty good chunk of change there. That because now, and I'm sure it's different in different localities, but I've heard that it's a minimum charge of over $600 for say a patient to walk in and just have something looked at the emergency room. And I would say it's probably a lot more than that in some of the more urban areas of our state. Go ahead.
I was going to say, and a lot of times I think it's just dental pain for something that's probably not real expensive to treat.
Right.
But it's very costly because they end up in the ER because they're in pain.
Well, I'm hoping that with the increase in oral surgery fees, that more oral surgeons will come on board and more general dentists will come on board and treat folks. Now this is just a general notice that we're seeing a lot of dentists that have just almost quit taking teeth out. If you need one out there, they'll refer it to the oral surgeon, and maybe that's why there's such a backlog getting a patient into the oral surgeon's office. Now that's a observation. I have no scientific data on that, but it just seems like the oral surgeons have commented to me about, well, dentist, you were trained to take out some teeth, but they're just not doing them a lot. But okay, I think that's got that. Is there any other just discussion points from any of the TAC members? Any other MAC recommendations? I would maybe just suggest that some of these questions, I know it's something that the MAC wouldn't have to vote on, but just to send them a list of some of these questions that we're asking DMS or the MCOs to research more for us. And I just, my opinion would be an appropriate thing to, make a motion on. But if you other TAC members don't think we should, well, then we don't have to. But John or Joe, you got any ideas on that?
I would honestly say, Garth, we need to, some of those are, I think John and I both are hearing from for the first time. So I think we would need to, I would recommend that we clarify those a little bit better before we make recommendations with them to the MAC.
Okay. All right. Now we need to look at setting our meeting dates for next year. And again, it just seemed like that Friday afternoons was a better time for all of us to get together. And so I put down some dates similar to what we had this year. And we
Dr.
can,
Bobrowski, this afternoon, I had sent out an email, and the dates you have listed are the same dates that I had recommended per your same schedule. I do know at one point you'd mentioned not liking to meet till 4 on a Friday. I didn't know if the TAC wanted to move it up an hour and go 1 to 3, or if you guys want to keep it at the 2 to 4 moving through next year.
Well, one reason, if I remember right, and Dr. Joe, you correct me, but I think with his schedule, the 2 o'clock Eastern time was about as early as he could get on the call.
That's correct.
Okay.
That's correct.
And I don't mind to leave it at that at all. And so, because I like you being on the calls here, Dr. Joe.
Well, since these are the same dates I have in the email, I will just mark them as approved by the TAC if you guys are okay with the dates listed down here, and I'll start working on getting the calendar invites out. We are currently on an uploading freeze with our website because we're trying to revamp it to make it a little more user friendly. So your meeting minutes from today won't get uploaded for about a week. And then so your meeting dates next year won't be added on there until about a week, until I've been lifted off of my freeze and I can edit the website. So I just wanted to let you know, just in case anybody goes out to look for anything from today's meeting, the website won't be updated till next week. I've just been trying to let some of the TACs know, because I know a lot of you like to go out and pull some of the information, or if there's presentations and things of that nature. So I've just been trying to give everybody a heads up.
Good deal. Thank you. And one quick question. I know you gave your name, but I didn't get a chance to write it down. It was from Research and Analytics.
That was Rachel.
Yes. Okay. Got it. Okay. Well, TAC members, is there any other business that we need to discuss? Well, we will please keep Dr. Schuler in your thoughts and prayers. And we are already in the process of looking for another TAC member. I really feel honored, to have, the TAC members that we've got. I think we've got a good cross section of what's going on in the state, and I really value these guys and gals for being on the TAC and taking the time to do these. And I really appreciate it. But if there's no other business to come before the TAC, I'll acknowledge a motion to adjourn.
Motion to adjourn, John Gray.
Second, Joe Petrie.
Thank you. All in favor, say aye.
Aye.
Thank you all. Y'all have a great weekend and have some fun.
Thank you. You too, Dr. Bobrowski.
Thank you.
Thank you,
Thank
Garth.
you.
Thanks, Garth.
Bye-bye.
Bye.